Buenas, ¿cómo están? Mi nombre es Juan Granada, presidente del CRF y profesor asociado de Columbia University en Nueva York. La charla que van a ver a continuación es una charla muy interesante que se ha convertido de verdad en una charla que Greg Stone da en todas partes, que es acerca del pasado, el presente y el futuro de los stents metálicos en general, con una transición hacia los stents bioabsorbibles también. Una charla muy importante porque para los que hemos estado en el desarrollo de stents desde el principio, hemos visto una evolución muy interesante en estas plataformas, desde el principio con struts muy gruesos, volviéndose más delgados, evolucionando a menos polímeros, ahora con polímeros absorbibles y algunas tecnologías utilizando no polímero para tratar de disminuir la inflamación arterial. Es muy interesante que estamos ya en un momento histórico de estas tecnologías en las cuales no vemos unas mejorías clínicas significativas con los nuevos desarrollos tecnológicos. Entonces es muy interesante porque no solamente nos va a ayudar a entender el aspecto histórico de la evolución de los stents metálicos a través del tiempo, pero también nos va a ayudar a entender un poco cuál es el impacto que estos desarrollos tecnológicos han tenido en el pronóstico clínico. Yo espero de verdad que disfruten esta charla, que es muy relevante desde el punto de vista educacional para los que son amantes de la cardiología intervencionista, y espero vernos pronto en el próximo episodio.
Okay, so here we go, my disclosures. So let's start with Andreas Grunzig. Okay, you all know about this. He really is the father of modern angioplasty. His first patient here is on the right, Adolf Bachmann, who we've actually had at TCT. And on September 16, 1977, in Zurich, he did the first balloon angioplasty. And it's very famous now. He developed the first balloon angioplasty catheter on a wooden table that was actually either in his kitchen or in his basement. There was always a glass of wine present, and this was really a rudimentary effort that transformed the world. This was the first balloon catheter, the Grunzig Delica DG2030, which was about twice the size of most common stents right now. So this was incredibly stiff. It had a fixed wire tip. It wasn't bent, so you really couldn't steer it. You had to kind of jiggle and jump the patient up and down on the table to be able to try to move it anywhere. So it was really only designed for very proximal lesions and straight arteries. Nonetheless, for the right kind of lesions, such as this straight proximal LAD, he could occasionally get reasonable results. And here you can see a nice balloon angioplasty result, about a 30% residual stenosis that stayed patent 10 years later with no significant restenosis. But of course, the Achilles heel of balloon angioplasty was acute closure. Because balloon angioplasty works by creating dissections, it's an unpredictable procedure. And we used to have surgeons standing by for every balloon angioplasty procedure because we would have acute closure in 5 to 10% of the cases requiring emergency surgery, and this usually caused a myocardial infarction and sometimes death. And this was just a disastrous situation. So stents were then introduced to take care of this problem originally, and these were the first two stents, the Cook GR2 stent and the Johnson & Johnson Palmar shot stent. Look at how rudimentary these look. These actually are the stents that we implanted in hundreds of thousands of people, but they worked. They actually markedly reduced or eliminated essentially the rate of acute closure. But the Achilles heel, of course, of bare metal stents emerged, and that was really restenosis. And restenosis would still occur in 20 to 50% of patients, depending on the lesion complexity. And we actually learned that these stents, while they were great at achieving acute gain, they actually caused more late loss than balloon angioplasty did. So then finally we got drug-eluting stents, the next generation, which added an anti-proliferative coating, an agent either initially with the first drug-eluting stents, paclitaxel on the Taxus stent, and sirolimus on the Cypher stent. And drug-eluting stents we always describe as having three components. The drug, the polymer, which is on the surface of the stent, which controls the dosing and release kinetics of the anti-proliferative drug, and then the stent itself, which initially in the early days were a stainless steel platform, which tended to be very thick and very difficult to deliver. Nonetheless, these devices were transformative, and they would allow us to take an acute stent result, such as this, and then freeze it 1 year later, 2 years later, 4 years later, 7 years later. And drug-eluting stents allowed us to markedly reduce restenosis. Not eliminate it, but markedly reduce restenosis. And we showed this in a whole series of trials. I had the honor to lead the Taxus trials in the United States, and there were a whole series of trials that were done with this. And in these randomized trials, you can see restenosis was cut down by about half, not 100%, not 80% like people think, but about 50% in non-complex lesions compared to bare metal stents. And you can see all that benefit is occurring in the first year, but then that benefit was frozen at years 2, 3, 4, and 5. So they worked in terms of restenosis. But then a new problem emerged, and whenever we try to solve an old problem, we tend to get new problems, and the new problem was very late stent thrombosis. We would get stent thrombosis with bare metal stents most commonly in the first 30 days and occasionally later. But with these first-generation drug-eluting stents, we noticed that they were thrombosing more frequently, but particularly after 1 year. So here is a tight lesion and a circumflex. This was a cipher. 2 drug-eluting stents were put in. Patient was fine, and then 3.5 years later presents with a myocardial infarction due to stent thrombosis. We again reported on this very openly and transparently, and both with Cipher and Taxus, there was no difference in stent thrombosis or myocardial infarction within the first year, but after the first year, there was an increasing risk of both stent thrombosis and MI. Not mortality, fortunately, but stent thrombosis and MI, and this led to a lot of discussion about how long dual antiplatelet therapy had to be maintained to try to reduce these complications. We learned, though, that there were a lot of problems from those first-generation stents that we could overcome with better technology to reduce that issue. One of the biggest problems with those is that there was vascular toxicity from the polymers that were being used. They weren't very biocompatible, and you wouldn't get complete healing. You wouldn't get complete endothelialization. So because of the toxicity, whereas bare metal stents will become completely endothelialized, usually in about 4 to 6 weeks, drug-eluting stents would only cover about 40 to 50% of the stent strut surface. We would also get underlying inflammation with giant cells or inflammation. We would get positive remodeling, again, because of vascular toxicity, and ongoing long-term inflammation, abnormal vasomotion, and other problems that would lead to these issues of very late stent thrombosis. So finally, we got the second generation, which really are still contemporary drug-eluting stents. People could talk about a third or fourth generation, but as I'm going to show you, we pretty much plateaued after this next generation stent. And many of these are still in use. And I would say that the first real 3 second-generation stents were the Xience stent, the Promus Element stent, and the Resolute stent. And here we had more biocompatible polymers of a different type. On Xience and Promus Element, they're fluoropolymers, which tend to be very thrombus resistant. The BioLinks combined hydrophilic and hydrophobic polymer was also very biocompatible. The stents got a lot better. The stents got thinner. They became mostly cobalt chromium or platinum chromium, so they became much more flexible and still acceptably radiopaque. And the drugs pretty much converted from to Linus analogs, either everolimus or zodorolimus, which compared to paclitaxel have a wider toxic therapeutic ratio. And with these second-generation stents, a whole series of randomized trials were performed. I again had the honor to lead the Xience stent program in the United States, and we looked at large meta-analyses of all the stent trials that were done, and this is now Xience compared to Taxus. And you can see there was about a 36% reduction in MACE, and that was because of improved efficacy. You could see TLR rates were lower, as well as particularly improved safety. So this was the biggest difference. We were able to reduce stent thrombosis by about 70% with these better second-generation stents compared to Cipher and Taxus. And you can see the biggest reduction is in this really early phase, although the curves do continue to keep spreading over time. You'll also note that there still are some very late events that occur, and as I'll talk about later, this tends to occur with all stents, not only drug-eluting stents. But now we've really equilibrated the playing field. So it's 2019, and I've brought you up to the present. So what do we need for the future? And why do we need better stents? Because the current ones we have are pretty good. Well, we still don't have 0% restenosis rates and 0% stent thrombosis rates. So we still need to work to get more effective and safe DES. In addition, there's tremendous controversy still on how long we need dual antiplatelet therapy. And we've learned that prolonged dual antiplatelet therapy causes bleeding, and that actually has been strongly associated with mortality. So especially for patients who are at high bleeding risk, we'd like to shorten dual antiplatelet therapy. And we'd also need to improve the lifelong prognosis after drug-eluting stents, because we used to say that after a year, everything was done. If you get through a year, we would tell the patient, no stent thrombosis, no restenosis, you're home free, okay? But we've learned that that's not the truth, and there's an ongoing risk of target lesion-related, stent-related events for the life of the patient. So what are the causes of adverse events with current drug-eluting stents? Well, one, even though the polymers and drugs we use are quite biocompatible, there still can be early and late inflammatory and hypersensitivity reactions. There's polymer irregularities that result in inconsistent drug delivery or can serve as a nidus for thrombus. There's still mechanical issues with the stents. Strut fracture still occurs, especially with the thinner stents, and longitudinal deformation can be an issue. And then there's very late issues that can arise with a permanent metallic implant because of either vessel straightening with loss of cyclic strain, loss of vasomotion, loss of the possibility of adaptive vascular remodeling, and particularly the formation of neoatherosclerosis, which is the transformation of restenotic tissue by lipid uptake into an acute unstable phenotype. So this is an example of what happens with polymers. The polymers that we're all using on DES are pretty elastomeric, which means they do stretch as the stent expands, but especially when you're passing a stent through fibrocalcific or tortuous vessels, the polymer can get stripped off. And you can imagine that if you end up implanting a stent without the polymer, one, that's likely a nidus for restenosis because the drug's not going to be there if the polymer's gone. But two, if you get too much bulking, clumping of the polymer, that could be a nidus for thrombosis. We still get fractures with stents, and sometimes these are very hard to see, but you look at them with very careful, with magnifying angiography or with intravascular imaging. You can see, for example, in this study, these are everolimus-eluting stents, 2 to 3% of patients with cobalt chromium and platinum chromium stents within 1 year had strut fractures, and these have been associated with aneurysm formation, restenosis, and thrombosis. And neoatherosclerosis may be the final common denominator in many cases of late drug-eluting stent failure and is not decreasing in prevalence as we improve our stents. So here you can see an OCT catheter. You can see the tissue that is within the stent struts. Here are the stent struts. This is tissue that's accumulated. This actually, lumen is probably okay. The patient may not be symptomatic for this, but you can see there's all these heterogeneous changes that are occurring in the deep parts of this tissue. There's neovessels that are forming, and this is lipid uptake. So the transformation of this. And then what happens is this can actually rupture the same way that any plaque can rupture, usually a thin cap fibroatheroma like the ones that Sunil Rao showed you, and then can get thrombus formation on top of them. And an autopsy series that Renu Vermani and others have done, looking at the frequency of neoatherosclerosis with cipher stents, taxis stents, and everolimus-eluting stents, still kind of the gold standard, there's really no difference. And the longer the stent's in place, the more likely the neoatherosclerosis is to develop. Patients can develop late ACS or late restenosis. So to further improve stent outcomes, there's a lot of strategies that people have been undertaking. One, we can make the stent struts thinner. Thinner stent struts endothelialize faster and may be less traumatic to the vessel. Two, let's have bioabsorbable polymers. If the problem is the polymer, okay, because of late inflammation, let's let the polymer completely absorb in the patient once it's released the drug, and then maybe we'll have less polymer effects. Or we can eliminate the polymer altogether. Maybe that's a good thing to do, and then we'll have no polymer-related inflammation. Or we can eliminate the stent. If the problem is that the stent is there for the long term, maybe the stent should only be there while it needs to do its job, which is probably the first 6 to 9 months or maybe a year to reduce constrictive remodeling of the vessel, to seal dissections, etc., deliver the drug, and then after that, the stent can completely absorb. So the same way you're not going to live with a cast for your whole life, you'll remove the stent once it's done its job. And maybe that would return vasomotion, adaptive vascular responses, etc. So let's look at thin struts. I think there was a lot of excitement with thin struts, and thin struts can be beneficial because either one, they may not cover side branches, so you may get less periprocedural myocardial infarction, or as I said, they may endothelialize faster, so maybe you will have less stent thrombosis and maybe a little bit less restenotic tissue because you'll get an obligate amount of restenosis to cover the height of the stent struts. So this was a moderately sized randomized trial called BioFlow 5, which led to approval of the newest stent on the US market, the Orsiro, which is a 60 micron cobalt chromium stent. It does use a bioabsorbable PLLA-based polymer releasing sirolimus. And it was compared to the standard Xience 82 micron cobalt chromium stent, which has this durable thromboresistant fluoropolymer releasing everolimus. And the primary endpoint of this study was target lesion failure at 1 year. And you can see there seemed to be a slightly lower rate of target lesion failure with Orsiro compared to Xience. Mostly because of fewer periprocedural complications, mostly small myocardial infarctions, and that seemed to be preserved over time. Shripal Bangalore and I published a meta-analysis from 10 randomized trials in 11,600 patients of what we called ultra-thin, less than 70 micron drug-eluting stents versus thicker strut, but second-generation drug-eluting stents, which were all about 80 to 82 microns. And here you can see if you looked at 1 year target lesion failure, this is cardiac death, target vessel-related myocardial infarction, or ischemia-driven target lesion revascularization, the most common way that we look at stent-related effects. You can see it seemed like overall, when you add up all these different studies of these 3 different ultra-thin stents, that there may have been a reduced rate of TLF, about a 16% reduction. You can see the upper bound of the confidence interval 0.99, so this is borderline statistically significant. So you have to be a little careful with p-values around 0.03, 0.04, but still there's no heterogeneity. It seems like a consistent effect. And this was driven by less primarily target vessel-related myocardial infarctions with no difference in cardiac death or ischemia-driven TLR. So what about stent thrombosis? Well, stent thrombosis is a pretty low-frequency event with all current contemporary DES, so we weren't powered in this meta-analysis to see differences in stent thrombosis. But if you look here, maybe there's a trend. You can see about a 26% reduction, but the upper bound of the confidence interval is 1.05, so not statistically significant, but it's trending in the right direction. Now, before we say for sure by going to 60 to 62 microns, this is a major advance, well, here's a trial that we didn't include in our meta-analysis, a large trial that was released after we published, which is Orsiro versus Onyx. So this is the Resolute Onyx stent, which is a very good current stent that releases zotorolimus from a durable polymer, and it's about 72 to 80 microns, depending on the size. 2,488 patients, and you can see looking at 1 year, in this case target vessel failure, absolutely no difference between the 2 devices. So there may be some advantage by getting a little bit thinner, but it's not going to be a giant advantage compared to contemporary drug-eluting stents. If we looked, interestingly, also at this Bionics randomized trial, surprisingly, stent thrombosis was actually less with the Resolute Onyx stent compared to the slightly thinner strut or Orsiro stent. Now again, if you look at these rates, 0.7%, 0.1%, totally underpowered to expect this kind of a reduction. This might be what we call a type 1 error, so play of chance because of these few numbers of events, and this would not have been statistically significant had there be 1 or 2 difference in stent thrombosis events. But nonetheless, at least from this biggest of the randomized trials so far, we don't see a major difference based on this relatively small reduction in strut thickness. So now if we get to the issue of bioabsorbable polymer-based drug-eluting stents, do they make a difference compared to durable polymer-based drug-eluting stents? Well, we published a meta-analysis of 89 randomized trials, okay, of 85,000 patients. And you'll learn a lot about meta-analysis, whether good or bad in interventional cardiology. And this was a network meta-analysis, so you can not only have direct evidence when stents were directly compared one versus the other, but you can have indirect evidence by comparing stent 1 versus 2. And if stent 2 was compared to stent 3, then you can make inferences of stent 1 versus stent 3. And this was the evidence network of all these different types of stents, from bare metal stents to first generation stents, second generation durable polymer stents, and bioabsorbable polymer stents. And if you looked here at the bioabsorbable polymer stents, which were mostly biolimus eluting stents, another limus analog, if we looked at stent thrombosis compared to bare metal stents and at least first generation DES, they seem to be doing better. But if we look at them compared to second generation drug-eluting stents such as Resolute or Xience or Promus Element, there seemed to be really no difference in terms of stent thrombosis. Same thing in terms of target vessel revascularization. Compared to some of the first generation drug-eluting stents and bare metal stents, they seem to be better, but compared to other contemporary durable polymer drug-eluting stents, there doesn't seem to be any difference. One of the best bioabsorbable polymer drug-eluting stents is the Synergy stent. This is a thin strut, 74 micron platinum chromium platform, which is highly flexible and deliverable. It elutes everolimus over about 3 months, and it has a luminal coating only of PLGA, which is a very, very thin coating of a bioabsorbable polymer that's totally gone within about 4 months. So you would think maybe within the 4 months, it won't be a lot of difference, but maybe long-term there will be a difference. Well, this was tested in a large trial, 1,684 patients, called the Evolve 2 trial, in which the Synergy stent was compared to the Promus Element Plus stent, very good durable polymer, fluoropolymer-coated everolimus-eluting stent, and this is the rate of target lesion failure at 5 years, and you can see these curves are absolutely superimposable. So the promise of bioabsorbable polymers really is not panned out. They're very good. The ones that we're using have quite low inflammation, which was the concern about their use before they were completely absorbed, but they don't seem to have improved long-term outcomes compared to the very good biocompatible durable polymers. Now, what about polymer-free metallic stents? Well, the concept is that here, once the drug's eluted, a bare metal stent's left behind. And there's potential advantages to getting rid of the polymer. One, you may get more uniform drug delivery. You don't have those problems that I showed you with the polymer becoming clumped or bunched or webbed. There shouldn't be any adverse polymer reactions if you don't have a polymer. And potentially there'd be more rapid healing and a shorter mandatory duration of DAPT. Because once the drug's totally eluted, now you've got a thin strut metal stent. And in the bare metal stent days, we only used 1 month of aspirin and clopidogrel. But there are potential disadvantages to not having any polymer. It's very difficult to control the drug dose and the elution rate. And some polymers actually may be beneficial. Some of them are actually thromboresistant and may have promote healing properties. So the most widely used and the most studied polymer-free drug-eluting stent, which I believe will come on the US market pretty soon, is the BioFreedom drug-coated stent. And what this is the first version of it is a stainless steel stent, and now they're converting to a cobalt chromium stent. But this is basically a 120 micron, so moderately thick stainless steel stent. The first one's up to Cypher were 150 microns thick, so this is kind of in the middle. And it's got this micro etched surface architecture, which makes all these little nooks and crannies that the drug can hold on to. And the drug that's used is a limus analog called Biolimus, but this is actually the most lipophilic analog that we have. So it's 10 times more lipophilic than sirolimus, which is the most commonly used other type of limus. And so therefore, as long as you can get some of the sirolimus to the tissue, it will be held within the lipid structures of the vasculature and have somewhat prolonged transient time. So this has very rapid drug transfer to the vessel wall, about 98% within 1 month, which is very good, and potentially avoid polymer-related adverse effects. And so the question is, can we shorten DAPT? And that's where this stent was really studied well. So the Leaders-Free trial was about a 2,500 patient randomized trial at patients at high bleeding risk, either elderly or on chronic oral anticoagulants or some reason where you wanted to have a short duration of DAPT. And these patients were randomized to either the Biolimus A9 eluting BioFreedom stent versus a very similar metallic bare metal stent. And 1 month of DAPT was used in all patients. So the first question was, is this a drug-eluting stent? Does it have efficacy? And the answer is it absolutely did. So the primary effectiveness endpoint was clinically driven target lesion revascularization, which is the best clinical surrogate for angiographic restenosis. And you can see there was about a 50% reduction in TLR. So this does act like a drug-eluting stent. So now, was it safe? Well, here are the components of the safety endpoint with the drug. We actually call this a drug-coated stent as opposed to an eluting stent, but that's okay. And you can see here there was no difference in cardiac death at a year. Myocardial infarction was actually reduced. And maybe this is reduced because of less restenosis, maybe a little bit of play of chance, but the safety concerns in terms of death myocardial infarction were all in the right direction. And stent thrombosis was no different. Although you'll notice both of these devices had a relatively high stent thrombosis rate. Maybe this is a little bit because of the thickness of the devices, or maybe this is because of the comorbidities of these patients, again, elderly, et cetera. But still, only 1 month of dual antiplatelet therapy. Maybe in both of these groups, if they had longer dual antiplatelet therapy, there would have been a lower rate of stent thrombosis. So to get to this, to see just how good a drug-eluting stent this is, the SORT-OUT-9 trial was performed in Scandinavia, and they randomized the BioFreedom stent versus the Orsiro stent. So this is that 60-micron cobalt chromium bioabsorbable polymer-based sirolimus-eluting stent. So this is now 120 microns versus 60 microns, and a polymer-coated versus a polymer-free stent. And this was a big study, all-comer study, all types of lesions, more than 3,000 randomized patients. But they did not try to reduce DAPT. They just really wanted to see if we use normal DAPT regimens, how effective and safe is the stent compared to one of the gold standard stents like Orsiro. So for stable coronary disease, they use 6 months of aspirin and clopidogrel, and for ACS, they use 12 months of either aspirin plus ticagrelor or prasugrel. And you can see here that their primary endpoint was non-inferiority, and target lesion failure occurred in 5.3% of patients with BioFreedom versus 4% of patients with Orsiro, so a little bit more in BioFreedom, but it met their criteria for non-inferiority. I'm sorry, it didn't quite meet their criteria for non-inferiority, so it's got to be less than 0.05. So actually, non-inferiority was not met. Now, if you looked at why it wasn't met, you could see cardiac death went in the right direction with this device, not statistically significant, very low rate of cardiac death, no difference in myocardial infarctions, but the big difference was target lesion revascularization. There was more target lesion revascularization with BioFreedom than the thin strut or Orsiro. So while this is a very good device, I think this study suggests that it's not quite as effective as contemporary very thin strut DES, although there was no difference in stent thrombosis. You can see at least with 6 to 12 months of dual antiplatelet therapy, the stent thrombosis rates were low, as you would expect. Now, the question, this has led to a whole field of how to manage the patient with high bleeding risk. And we've gone from a focus on trying to extend DAPT duration and make it longer to make it shorter. And the current, you're going to hear a lot about this in the course, the current standard is 6 months in patients with stable coronary disease and 12 months in patients with biomarker positive non-STEMI or STEMI. And you may shorten those durations or lengthen those durations depending on the relative risks of ischemia versus bleeding. So BioFreedom is right now the standard for 1 month of dual antiplatelet therapy, but maybe it's not as effective as some of the other stents. So the question is, can these other stents now be safely used with short durations of dual antiplatelet therapy? So we just had the randomized STOP-DAPT-2 trial that was just presented at the American College of Cardiology. This was a study, very interesting study, 3,000 randomized patients, and these were pretty much all comers with few exclusion criteria, although they did exclude patients who were on oral anticoagulants. And they were randomized to dual antiplatelet therapy for 1 month. All the patients got that, and then they basically dropped the aspirin in half the patients and continued it. They dropped the aspirin in half the patients, so they got clopidogrel alone for the next 11 months, where half the patients got aspirin and clopidogrel for the full 12 months. All these patients got Xience. They were treated at 90 Japanese centers. So about 40% of the patients did have acute coronary syndromes. They're at higher risk for stent thrombosis, but these were very simple lesions. The mean syntax score of these patients was 8. So this is like single low-risk patients, and they use intravascular imaging in 98% of all these patients. And this is the way, this is not unique to this study. Japan, almost 100% of patients throughout the whole country get intravascular imaging during PCI, and that really reduces restenosis and stent thrombosis, as you'll hear later in this meeting. So their primary endpoint was NACE. So NACE is net adverse clinical events, which is major ischemic events or bleeding, and you can see major ischemic events or bleeding was substantially reduced in the 1 month DAPT patients versus the 12-month DAPT patients, p-value of 0.037. So when we break it down into the components, You can imagine the secondary endpoint of TIMI major or minor bleeding by having 11 months of less DAPT. This is where you would expect to see a difference, and this is indeed where there was less of a difference, about a 75% reduction in major bleeding events. And TIMI minor bleeding, don't be mistaken, is major bleeding. Okay, so this is a very relevant reduction in major bleeding by going to 1 month of DAPT. But the real question is, with a stent like Xience, is it safe from an ischemic point of view? And their primary MACE endpoint here was cardiovascular death, myocardial infarction, stent thrombosis, or stroke. And here they saw no significant differences. But what you've got to note is that these rates are incredibly low. Okay, and these are very, very simple lesions, totally optimized by intravascular imaging. And so while this is an incredibly positive trial, suggesting in these very simple lesions, if you implant them with IVUS, especially in a Japanese population, which already has a very low rate of stent thrombosis for genetic reasons and others, that then it seems 1 month of DAPT with Xience stents is certainly safe. So we need more data in much more complex patients, but so far this was a very positive study. So there's a whole bunch of other studies that are coming out to look at multiple other types of drug-eluting stents in the high bleeding risk patients, from Synergy to Xience to Ultimaster. Some of these are randomized, some of these are registries. STOP-DAPT-2 is out, as I just showed you. The senior trial with Synergy was also a positive study and showed that 1 month of DAPT with Synergy in patients who were greater than 70 years of age was safe in patients with stable ischemic heart disease. 6 months was safe in patients with acute coronary syndromes. I'm very excited about one of the trials that we're involved in, which is the Onyx One Trial, which is a randomized trial of the Onyx Resolute stent compared to the BioFreedom stent in 1,000 patients with high bleeding risk characteristics, almost identical to those in liters free. So that's going to really be a study that I think, at least in 2,000 patients, it will show us can we be somewhat more effective than BioFreedom with a contemporary second generation DES, but still be as safe with only 1 month of DAPT. And we expect to have those data for you at TCT. So once you guys graduate from the fellows course this year, we'll expect to see all of you at TCT in San Francisco in September. And again, as part of the commitment to all the fellows from the Cardiovascular Research Foundation, registration for even a meeting like TCT, normally as high as $2,000, is free for the fellows. So let's finally get to bioabsorbable scaffolds. You all probably are aware somewhat of this story of bioabsorbable scaffolds. There was a lot of excitement about these agents or these devices, and they were approved on the US market. They weren't removed, but they're no longer being commercialized. So what was the whole rationale behind BVS or BRS? And I spent a lot of time on these as well. So why do we need a bioabsorbable scaffold? Totally get rid of the device. Well, metallic drug-eluting stents are associated with an ongoing risk of very late stent-related events. And as far as we can tell, this is lifelong. There's also suboptimal outcomes in special situations, such as high stent thrombosis rates in STEMI and non-STEMI. With bifurcations, a permanent device, of course, jails side branches for evers. With diffuse disease, you leave a full metal jacket, so you reduce late bypass surgery options and restent options. The best treatment for in-stent restenosis is probably another drug-eluting stent, but then we're putting a layer of stent inside each other. That has an obligate space-occupying effect. We'd rather not do that. So for all these reasons, it'd be great if the scaffold or the stent would just disappear. And in addition, a permanent implant is just not desirable for many patients because of either cultural or religious reasons. They'd rather know that there was nothing foreign left in their body. So this is some of the data that people are just now starting to realize about the long-term effects of drug-eluting stents. And these are target lesion-related, stent-related effects. This was from a Japanese study that followed 405 patients after bare metal stents for up to 20 years. And you can see, while with bare metal stents, whether you look at cardiac death, target vessel MI, or add target lesion revascularization, while there are relatively high rates within the first 30 days, you can see that after year 1, there's about a 2% rate per year of these events that continue through at least 20 years in patients, and there's no plateau evident, and it's very linear. We've looked at this, and this is a paper that we've recently submitted for publication, looking at target lesion failure-related events between 0, 1, and 1 and 5 years in 17 randomized trials of 22,000 patients. And you can see as we've gone from bare metal stents to first-generation DES to second-generation DES, yes, we certainly have reduced target lesion failure within the first year. But afterwards, from years 1 through year 5, there's about a 2% per year event rate arising from the stent every single year with no plateau evident. And these are very dramatic cases. This is from the bare metal stent series. This is a patient who had a focal LAD stenosis, gets a stent, looks great. At 5 years, it looks great, and then suddenly presents with unstable angina due to in-stent restenosis. 15 years later, right in the middle of the stent. Here's a patient with another LAD lesion, very focal, very large vessel, gets a stent, looks just great. Here it is 2 years later, and it looks fantastic, and then presents with a massive anterior myocardial infarction 17 years later because he thrombosed the stent. So I told you there are issues and what the long-term issues are, in particular neoatherosclerosis. Maybe we can reduce that. So absorbed BVS of many bioresorbable scaffolds was the one that was most widely developed. And this, again, was a polylactide-based device. PLLA has been used in many other bioabsorbable applications, such as sutures, et cetera. It was a first-generation thick strut device, 150 microns, and it had another 7-micron coating of polymer to release everolimus. But it was fully bioresorbable, and within about 3 years, it would be totally gone. So this is what we know. Here's what it looks like in animals at 1 month, 12 months, 24 months, it's filling in with this extracellular matrix, and by 36 months, you can no longer detect PLLA by mass spec. And in patients, by OCT, we would see the same thing. Here it is at 1 month, you can see the struts, you can see it's got some tissue and it's covering it, and here it is at 12 months, 36 months, basically the struts are gone and it's filling in with glycoproteins and collagen and other matrix-type materials. We know that if you take a bare metal stent, it will be there forever. So even though here's a very wide lumen 5 years after a bare metal stent, you can see that the somewhat obligate neointimal tissue is already having lipid uptake and transformation into an unstable phenotype. 5 years after a bioresorbable scaffold, this was the dream. You've got a nearly normal-looking coronary artery. If new plaque develops, it can grow outside, the Glegg-Goff phenomenon that you heard about earlier, as opposed to any new tissue here has to just grow inside the stent. This could theoretically have normal vasomotion and a lot of other benefits. This is the only device where the artery can grow over time. Again, with a metallic stent, there's an obligate narrowing over time of the lumen, where with a bioresorbable scaffold, the arteries would grow over time. And there's a lot of other advantages. I mentioned to you, for example, bifurcations. Metallic stents, here's an OCT, this is a side branch of an LAD diagonal, and this diagonal is covered. This is never going to go away for that patient. On the other hand, here's a bioresorbable scaffold over an LAD diagonal, and here it is at 1 year, here it is at 3 years, it's now totally gone, and at 5 years, even the side branch lumen tends to get a little bit larger. So there's a lot of theoretical reasons why this should be a good thing. Unfortunately, data ran into all of these concepts. And we ran a lot of trials. There were 4 main early studies, randomized trials of bioresorbable scaffolds, the BVS versus Xience, both for eluting everolimus, 3,389 patients, so a large series. And what we saw particularly was that the 3-year rates of device thrombosis were unacceptably high. Now, they're not terrible, okay, but it's 0.6% versus 2.3%. So it's clearly almost 4 times higher. So the absolute difference was 1.7%, but this is unacceptable. And what this led to was an increased rate of target lesion failure. Now, I told you that it takes 3 years for these devices to be gone. So it's really after 3 years that we're going to expect to see the benefits, from 3 years to 10 years or 20 years. And many of the patients, of course, are in their 60s, some younger, and are going to have these devices for 20 or 30 years. So we would need really long-term follow-up to see the benefits. Well, we just now have 4-year follow-up, and at 4-year follow-up, if you look at target lesion failure, you see the difference within 3 years, but then from 3 to 4 years, we start to see minimal differences. And in fact, here's device thrombosis, which was the most concerning effect, and you can see, and this occurred because of a lot of reasons, the the thick struts of the stent, other phenomenon of intraluminal scaffold dismantling, et cetera, that we can talk about during discussions. But if you look here, after 3 years, once the devices are gone, there was no further increase in scaffold thrombosis. And in fact, if anything, it seemed like it was going in the right direction. So unfortunately, we never got to long-term follow-up or long-term outcomes because of these early safety issues. So how can we improve BRS outcomes prior to their complete bioresorption? Well, we've either got to improve the technique, and we've learned, which we didn't know at the beginning, that these devices take specific technique, which has been called PSP, appropriate pre-dilatation, appropriate stent sizing, and post-dilatation, routinely, non-compliant balloons, slightly oversized. They're more reliant on intravascular imaging, especially with the first-generation devices, to make sure that you get good malapposition and potentially prolonged dual antiplatelet therapy. But as or more important would be to improve the device. I mean, these first-generation devices were just way too thick at 150 microns, so we need much thinner strut devices, and there you get into a trade-off of mechanical performance, given that the polymer is like a plastic, it's not as strong as a metal, and we have improved mechanical properties. We need improved mechanical properties, such as resistance to recoil, flexibility, et cetera. So the good news is that there are a lot of better devices that have been developed. Again, they started as high as 228 micron thickness, and now there are some bioresorbable scaffolds that are below 100 microns, even as low as 80 microns, that have the same or slightly greater radial force than these early ones. So hopefully some of these companies will still be able to survive the commercial challenges. We are hopeful that Abbott Absorb BVS will come. Now they've got a 99 micron version, and we're hopeful that they are going to come back into clinical studies in the near future. So if I was just going to conclude, and this is an incredibly fast whirlwind presentation of the past, present, and future of drug-eluting stents, it's been an incredibly exciting ride with many twists or turns. Stent technology is now a mature, and coronary PCI is a mature subspecialty. We've gotten to the point where we can really reliably treat 99% of lesions, and in probably 90 to 95% of patients get good, durable, safe, long-term results. But we still have, in the most complex patients, some challenges, which is why, of course, we still have discussions in multivessel disease and diabetics, PCI versus surgery, et cetera. But I am convinced that with a lot of smart people and all these great technological innovations, that the best is yet to come. Thanks very much.